We heard a lot about the acute pancreatitis with respect to the pediatricians this morning, that we know that this is the acute pancreatitis is one of the most common diseases of the gastrointestinal tract that require acute hospitalization and is associated with significant morbidity and mortality. And this is what I already told you about, that what we were focusing on with respect to the registry in the acute pancreatitis, so the clinical features of the patients. These data were prospectively collected but retrospectively analyzed. What we can see here that the patients number in 2013, we had over 200. In 1 year, it more than doubled, and since then, in the last half year, we already again gained more than 200 patients. So altogether, we have now 650 patients with acute pancreatitis in our registry. As the acute pancreatitis is associated with significant morbidity and mortality, requires an up-to-date and evidence-based treatment guideline. What is the evidence-based medicine look like, and what does it mean? So it's a process of turning clinical problems into questions and then systematically locating, appraising, and using contemporaneous research findings as the basis for clinical decisions. Based on this, the IAP-APA actually 2 years ago provided a guideline for the management of acute pancreatitis, and this guideline is based on currently available evidence. And these recommendations should serve nationwide, worldwide, as a reference standard for the treatment of acute pancreatitis. So in this respect, our aim was to collect the data of the patients with acute pancreatitis, and we wanted to analyze the patient information and evaluate the clinical outcome based on the recent guidelines using the database. So we wanted to compare the clinical outcome and the clinical features of the patients to look at if the guidelines, the international guidelines, are strictly used, or are we using those guidelines, or we are not using the guidelines. So this is something that we have to look at the mirror and look at the data. So our methods, as I mentioned, that it was a retrospective clinical analysis of prospectively collected data. We collected data between 2011 and 2014, and at that time, we had more than 20 different centers, and altogether, we analyzed data of 474 patients. The gender, you can see the genders, there was no big difference between them, so we had females and males as well. And the diagnosis was made according to the consensus 2012 Atlanta classification, that the symptoms, the elevated serum levels of pancreatic enzymes, and then clinical imaging, so 2 out of 3 criteria. And when we first look at the etiology, these are the total patients, so it means that the females and the males together. And what we can see here, that the biliary and the alcohol is the biggest part in terms of the etiology. But if we divide them into genders, we can see in females that the biliary is almost 50%. With respect to the alcohol, it's just 5%. But in male patients, actually, it shows as it's in the literature that one third of the biliary and the acute and the alcohol etiology, the cause of the acute pancreatitis. When we looked at the clinical outcome, at that time, the registry, and also it was before the Atlanta classification in 2012. So at that time, we didn't compare, and we didn't have the severity of mild, moderate, and severe patients. At that time, we were just collecting data in that way, that we were looking for severe and non-severe patients. And from this, what we can find here, that altogether we had 78 severe cases, what is like 16% in all patients. In males, it was a little bit increased compared to females. With respect to the mortality, we look at the all patients. The total mortality was around 3%. So it's 14 patients out of 474. When we look at the These are in the green bars. But when we look at the severe patients and mortality among the severe acute pancreatitis patients, you can see that the overall mortality is 16%. We have a little difference between the genders. In males, the mortality is a little bit increased compared to females in severe cases as well. So this is what I said, that having the evidence-based guidelines, and according to the guidelines, what is suggested, what kind of therapy should be used in patients, we also looked at in our registry, so how do we cure our patients? And the first thing what we looked at, one of the most important what we heard this morning, is the IV fluid resuscitation during the first 24 hours. And what the guidelines says that the fluid therapy should be at least 2,500 ml during the first 24 hours. So we looked at the results, the data, what we can find in the registry. And these are the total patients. And what we can see that 77% of patients received IV fluid infusion, but 22% didn't get any fluid IV during the first 24 hours. Those patients, when we analyzed, according to the guidelines, that if the patient received 2,500 ml or more, it was less than 50%. And those patients that didn't receive, we can see with respect to the clinical outcome, that those patients that received less than 2,500 ml during the first 24 hours, we could see more severe cases and the mortality was also increased. With respect to those ones, we see that the severe cases and the death in those patients that received more than 2,500 ml is less than in those that the ABM guidelines were not actually accepted, not used. The second thing was the enteral, jejunal nutrition. The guideline says that for enteral tube feeding, the primary therapy is in severe acute pancreatitis, the nutrition. When we looked at our data, again, all patients, we can see that almost the 3/4 of the patient did not receive any kind of enteral nutrition. We know that we have just few severe cases, but when we look at the severe cases and look at the enteral feeding in severe cases, we can see that 78% of the severe cases received enteral nutrition, but 22% didn't receive. When we look at this group, they didn't receive enteral nutrition, and look at the clinical outcome, you can see that almost 50% of these patients, this is 17 patients didn't receive enteral nutrition, 8 of them died. So this is also a fact that we can see that the EBM guidelines, the recommendation consensus guideline says in enteral nutrition, acute pancreatitis in severe cases. If we don't give the patients enteral nutrition, the mortality increases. The third thing is the analgesics and the antibiotics. Grade 1B, strong agreement, what we can see here in the consensus guideline, that the antibiotic prophylaxis is not recommended in acute pancreatitis. When we look at our data, we can see that the analgesics is more than 70% administered to the patients, but when we look at the antibiotics, it's more than 75% of patients. So the question is that why those patients, almost 3/4 of all patients, receive antibiotic treatments. So in this group, we don't know if the patient had pneumonia or they had cholangitis. So we have to look very strictly and carefully in this group. But even if we don't know these data, we see that in all patients, the antibiotic treatment is increased. So in summary, we can say that the most common causes of AP in Hungary is biliary and alcoholic. The alcoholic component is much less frequent as in females than in males. The majority of AP cases is non-severe, but there is no substantive difference between the genders in terms of the clinical outcome. And the mortality in severe cases in non-severe cases is very rare. However, the mortality in severe cases exceeds 15%. The administration of IV fluid resuscitation and enteral nutrition is far not optimal, which draws serious consequences in terms of clinical outcome and the mortality. And the use of analgesics is high, but the antibiotics are administered very, very frequently with questionable indication in the majority of patients. So the information about the etiology, the clinical features, outcome, and the patient therapy offers and consultation opportunity for our physicians and for us, which can infer further understanding and management improvement of the disease. And what we can see that the high prevalence of the associated significant morbidity requires regular national consensus meetings and up-to-date evidence-based treatment guidelines. What Peter this morning mentioned, that we already have the Hungarian guidelines. They are under publication, so they are in press right now. So we have the guidelines. So having the guidelines, what is the most important right now, that we have to disseminate and implement these guidelines to use for each physician. And this is very, very indispensable for improvement in patient care. So let me acknowledge and thanks for the centers, for patients, and for contribution. I'm looking forward to work together in the future. Thank you very much.
Thank you very much, István, for this nice data analysis. The paper is open for discussion. Any question from the floor? Yes, please.
So very nice presentation. It definitely has direct implications to the work that I enjoy. When you analyze the patients who received less than 2,500 and the patient population who got more than 2,500 IV fluid resuscitation, you also mentioned you had 22% that did not receive any IV fluids. Did you look at the outcomes in those compared to the ones who got suboptimal IV fluids or even the recommended IV fluids?
Those 22% of patients, the majority of those patients are arriving in the evening. So actually this counts the first day, as the first day. So analyzing that, we have to go back and look at that those patients just arrived. And so what we can see and what we can get information from the registry right now is that the first day, if they received or not. So it means that the patient arrives is admitted to the ER, and when it goes to the ward, so maybe those 2 hours before midnight, maybe those patients they don't get. So I don't know. I can't answer now your question. But when I looked at directly, so with respect to the medical history and the record, it says that mostly those patients arrived in the evening. So most probably that's why they didn't receive the fluid resuscitation.
And thank you very much for that comment, because we continuously try to improve our data management. So because we found it and there is something odd here, now we have changed the management, we have changed the data collection, and now we have data at admission, therapy at admission, and after the day one is called on the first day when the patient's admitted to the department. So from now, we will be able to tell whether at admission what the patients get, and after day 1, day 2, day 3 what the patient.
So we will really know the first 24 hours. That's going to be the first 24 hours, because now the first 24 hours can be less than 24 hours, because it's the first day.
A way I overcome this in our population is just exactly what you mentioned. I just put everything in hours. That's why when I showed my length of stay, it was all hours.
Exactly.
I could convert it later to when I divide the 24 hours and give you the dates, but because of that reason,
it's a very good idea. Thank you.
István, do we have data from the ER management of these patients? Because most of them are spending half of their day, the first day in the ER, so we should count for that also. So
retrospectively, we don't. But now, as Peter mentioned, that now the new system started. And with respect to, so I'm going to also introduce the EASY trial. So everything starts from the ER. So we'll have the data. So we already started to collect prospectively those data, so we'll have data on ER as well.
And the other question, if I may, did you analyze those antibiotics treatments regarding the etiology of the pancreatitis? Let's say in acute biliary pancreatitis, did the patient receive antibiotics?
Mostly yes, in ABP patients, yes. What we have to go back and look at is if those patients had also cholangitis. So this is what we don't know right now, that mostly I can say that it wasn't 75%, it was almost 90% of the etiology of biliary etiology of acute pancreatitis, but we don't know that how many percent of those patients had cholangitis as well. And those patients, they need antibiotic treatment. Professor Whitcomb is.
Thank you. Next question.
I may have missed it. Are you recording the exact time when the pain started? Because that's the way many of the acute pancreatitis studies are being timed now. It's the time of the onset of pain, and then everything is keyed off of that.
Now, yes, as the new registry, actually, we renewed and we started a prospective new collection of data. Now we know everything from hour to hour, and we will also know the onset of the clinical symptoms, or at least to know that before admission how many hours the pain started.